Welcome back, everybody. This session is really going to be about World Health Organization UNICEF guidelines for child health. And I think that it's important as we look at, okay, we've sorted out some problems in short-term medical missions in the morning, but what we want to do really is figure out how do we address those problems? How do we develop strategic ways to engage the community? One of the things that many years ago I worked full-time with Mercy Ships International, and as part of a team that really tried to figure out how to fit short-term medical missions into kind of long-term development projects. And one of the things they said to me initially was, you're going to bring short-term medical teams to our development projects over our cold dead bodies, I think was the words they used. And I said, well, that's not very encouraging, right? But we had to figure out ways that we could strategically use short-term teams to come alongside community projects to really bolster what they're doing. So we tried to come up with some ideas. And I would encourage you to communicate and talk about these things because there are really good ways to do this. One of which is some of the standards and guidelines that we're going to talk about, this what we call integrated management of childhood illness. Before I get into that, I want you to kind of give you a vision for what we did when we were with Mercy Ships so many years ago. When we did short-term teams, we said, okay, we're going to go in and we're just going to see kids from 0 to 5 years old, and we're going to see pregnant moms. And that narrowed our community down when we were doing community-based care model. But what did that enable us to do? It enabled us to look at really what is the health of that community, and what is the health of the kids in that community, and what are the health of the moms of that community? What is our disease prevalence? What is our malnutrition prevalence? We could weigh, measure, and graph 1,000 kids in a week with a primary care medical team that was focused on pediatrics. But by looking at the health of kids in these communities, you can get such a great picture of what the health challenges really are. So now I took these teams and we did this, and now the development teams had all of this data to say, okay, this is our starting point for this community. Now we can go back and reassess this in 6 months. We can go back and reassess this in a year. We give the short-term teams a really functional way to plug in to do monitoring and evaluation of strategic health programming. And at the same time, we feel a need because all of the funding out there for community health programming is data-driven. So if we're not collecting the data, if we're not looking at the outcomes, nobody's going to give us any funding to do these projects. So by taking this approach, we made the programs that we were doing more fundable because we can monitor, evaluate whether they're effective. We could transfer and transition some of the things that were not being effective into things that were more effective. So that's how we stumbled on to IMCI, was that when we were looking for a program and a set of protocols to really help those child health teams be effective in this regard. So when we look at guidelines, this section is going to look at primarily child health. And you know, none of us want to look too much and too closely at guidelines and standards. None of us like this in hospitals here. They're no fun. They're not, if anybody says the word JACO, everybody cringes and runs the other direction, right? But World Health Organization wasn't designed to do that. It was designed to give us a set of guidance notes to head in a certain direction to do things at a higher standard of care. And, one of the big things that I want to share with you is, this is an old slide, but you'll see it frequently. The data is pretty much the same other than the total number of child deaths from age 0 to 5 years has come down maybe marginally, maybe by 500,000 to 1,000,000, but ultimately we're still looking at about 6 million kids who die under the age of 5 every year. And the breakdown remains pretty consistent as to why they die. What we want to look at is why did we go, though, from 6 million, or where we're at 6 million now, from really 12 million not that long ago, a little over a decade ago, 15 years ago. And probably the biggest reason for this significant drop in under 5 mortality has been this program, Integrated Management of Childhood Illness. IMCI is a set of protocols that helps us look at and assess every child the same way. And every child that appears to us under 5 years of age is going to get assessed the same. They're going to get the same paperwork filled out. They are going to, and what that does is, you see, they developed an integrated approach because children in the developing world don't present with one problem. Very rarely do you see a kid who comes in and dies because he had one health problem. He's got this undergirding malnutrition. He's got pneumonia. He's got this terrible cycle of disease and malnutrition and all these underlying problems that if you address just one of them, the likelihood that you're going to be able to save this kid is pretty limited. So what WHO did was develop, everybody's familiar here with ACLS, right? Or most of the medical providers. They developed kind of a set of protocols that said, okay, we're going to develop this set of protocols that a community health worker with a 6th grade education can learn all the way up to a physician. And we're going to color code, it's a color-coded triage system. We're going to color code this system, and we're just going to place kids in these categories as they come in based on the questions that we're going to talk to mom about. And by doing that, they created a system that ended up being a safety net where where they would catch these kids that were potentially critically ill or were critically ill that were getting missed, especially at the health outpost level. So this program has been instrumental in the drop in community, in the number of child deaths under 5, and they've been a real remarkable piece in the community. By the way, this ICAT training program. This is available on our website in our resources section so that you can go to this and download this and just kind of eyeball it. Now, if you were to take an IMCI course, and I've taught IMCI courses before, it's usually an 11-day case management program where you're doing classroom work one part of the day and clinical work the other part of the day. But most of the people in this room, if you're a clinician, if you're a healthcare provider, most of us can go through this material and be pretty comfortable with it without too much of a problem. The other thing that you want to think about is getting the paperwork. Now, there is an IMCI chart booklet on the website you can also download. I have a copy of it here. I'll show it to you if you're interested after. But it shows how this color coding system works. Now, what happens is as healthcare professionals, we look at this and we say, oh, well, they're throwing these huge nets and creating these diagnoses for things that don't really fit the diagnosis. But in reality, what they are is they call something pneumonia or severe pneumonia, very severe pneumonia, or severe pneumonia or very severe disease. They're using that as a classification rather than a diagnosis. As a clinician, they want you to look at specifically what is your diagnosis. But this is, okay, how can I teach the public health nurse, the community health nurse who may be trained at an LPN level or lower, how to assess every kid the same way? So if you use the same paperwork and then you just go and look at this system, it's pretty straightforward. Now we teach quite a bit of this in our Global Health and Tropical Medicine Overview course that we do here in Texas every year, because it's an essential piece to doing, I think, to doing healthcare in the developing world well, and especially if you're doing it at the village or community level, this is a piece that you want to keep in your toolbox. And it's a piece you want to use because it will help you catch those kids that are potentially going to die. It's also something you can leave behind, which I think is really valuable when you're working with a community health, a community health, rural health outpost. Being able to work alongside somebody in these protocols. Plus, one of the things that I try to express to healthcare professionals here is that these protocols are being taught in medical school and nursing schools overseas. But what happens is when we step into that environment, we don't use them. And we are looked up to professionally because the training is a bit different here. And people expect us to come with a higher level of training. But when we're not using this, what does this tell the community? Those that have been trained to use these protocols, then we don't use them. So we want to try to get people really thinking about how do you grab onto IMCI, how do you use it in your short-term medical work overseas. The WHO UNICEF guidelines are really focused in these four areas: patient safety, health education and counseling, prevention, assessment, and treatment interventions. So it's really broken down into how do we, obviously we need to sustain patient safety when we're treating children in the context of healthcare delivery. Every mom should be counseled on when to seek care when they come out of the clinic. Because that's probably one of the biggest factors in these children dying is the delayed care-seeking behaviors. Sometimes that's economic, sometimes that's a knowledge deficit. So we have to be real clear on when mom is supposed to bring her child back and what conditions. So IMCI covers a range of danger signs that we teach moms as they come through the clinics. Prevention, this is a biggie and goes back to the immunization level, right? I mean, we all know these kids need to be immunized, but what does that look like in the places that you're working? And then obviously assessment and treatment interventions. So let's we're gonna move through these. I think when we talk about patient safety, this was the one I brought up this morning. This is, moms of children prescribed home medications must, for each child, verbalize the medication instructions, demonstrate measuring the dose whenever possible of the medication, administer the first dose of the medication under the supervision of a licensed person. That's a standard here. It's a standard everywhere we practice. So just because we want to see more patients doesn't mean we drop these basic standards. We want to attempt to limit the number of, comes right out of the IMCI guidelines. We do want to attempt to limit the number of prescriptions for a young mom with a bunch of kids. We saw what happens in Maria's story, that's a potential disaster if we're not careful. So write your prescriptions carefully and select them carefully and try to avoid polypharmacy. And then obviously we want to make sure that mom really understands and that dosages are divided per child. But again, that idea of private pharmacy consultation areas is really very important here. And that also comes right out of the IMCI guidelines. So when we talk about health education, we're talking, like I mentioned earlier, this idea of care-seeking behaviors plays really huge into young child or under 5 mortality. Nutrition, that's the other area of education that we want to look at because, and we've got to be careful about how we address these issues because it can really shame moms when we are not careful about how we address these issues. And we have to use that C word we talked about this morning. It's really about compassion and really demonstrating love and mercy and care to mom. Otherwise, mom feels like, oh, I'm such a failure because I'm letting my child starve to death. even though her social context is such that it's a disaster. But so when we address these issues in education, we have to do it with sensitivity. And we have to do it with understanding that her life, when we ask her to do things like boil water, we're adding a whole lot more workload onto her life. So we have to think about the context that she's living in, and the ability for her to carry out what we're instructing her in. Home management of diarrhea and dehydration, and then malaria prevention. So those are our big areas of education. Probably the biggest area, though, of that we need to address, pretty much every patient needs to hear, is when to bring their child back. This idea of poor delayed care-seeking behaviors contribute to 70% of the under 5 deaths globally. So every child should, or every mom of a young child should be counseled as to what are the danger signs that she has to be concerned with. When we talk about general danger signs, these are real simple. The child is unable to drink or breastfeed. The child vomits everything. The child has convulsions, and the child is lethargic or unconscious. Those to us, when that child, I don't know, how many nurses do we have here? We have any ER nurses and docs? When a child appears in this condition in the ER, we go, wow, everybody's on this kid, and we're putting lines in him, and that's not the case here. One of the big challenges that I have is I get to pastor a group of about 60 some doctors now spread around the world, and most of them are seeing many of them are seeing upwards of 100 kids die a year, when they may have saw 2 or 3 die a year here. And that in itself is incredibly challenging when you step into that context and you haven't been trained in that environment to see that day in and day out. And most of it comes back to that delayed care-seeking behavior. So we can do a lot by counseling mom when to seek care. Those basic danger signs are how we arrange the questioning in the paperwork in the IMCI chart booklet. We have to remember that 53% of child deaths globally is underlied by malnutrition, and that's something that we can't ignore, and we have to assess every child for severe acute malnutrition. What's wrong with this baby that you see here? Who sees that child is malnourished? Some of the more astute clinicians, but sometimes if you're not used to seeing kids like this, you could miss it so easy. But look at his feet. You have severe kwashiorkors. And kwash, if a kid has pitting edema like this, that's admission criteria. That kid has to be admitted to the hospital. Unless you have a real strong outpatient nutrition program and they're still eating, then you might be able to do it on the outpatient level, but more than likely you need to bring this kid into the hospital. That is one of our kids from Lindsay, who I showed you guys this morning. She runs the only severe acute malnutrition inpatient program in Eastern Congo. So she gets about 200 kids through that program that can't walk, can't stand, can't eat every year. And she has only about a 10% mortality, so she saves the majority of them. But she's able to do that because it's a long process. These kids are admitted for 2 to 4 weeks, and then they're discharged, but they're kept on site for another 6 weeks to 3 months, where moms are put into a group biblical counseling program where they learn what does it look like to provide nutrition for their children, even in these resource-poor settings. And there's a lot of tricks they can really take on that we can educate. So a lot of it is educational, but moms also learn in this context. One, the hospital is a safe place and there's no shame. And if their baby gets like this again, they can come back. That's number one. That it's a place that they can feel safe and loved, and they'll always be taken back if they're in this situation. And two, they're able to participate in a support group and grow together and learn together. And the moms really do transform more than the children. So that's kind of cool to see. But this is a process. If you want to keep the readmission rate down on these kids, the only way you're going to do it is to plan out. This is a 3-month process. And it doesn't usually happen much faster than that. But if you do it well, you'll never see these kids again. And that's the underlying goal. But the big thing that we have to get across to moms is breastfeeding for kids, exclusive breastfeeding for kids 6 months and under is a must. And if we can get that to moms, that's important. But sometimes mom's economic situation doesn't allow that, right? Mom is working in the neighbor's field and she's leaving her infant to be cared for by her 6-year-old. And so you have to be sensitive to the social construct of what you're engaging with and just love mom and get her to open up to you and realize that she may know she's supposed to breastfeed. She may want to do that with all her heart, but she's not able for any number of reasons. So get ready to stand with her and kind of explore what that looks like. But this is the one thing that could save up to almost 1 million kids a year if we could get moms to exclusively breastfeed. And so that's a huge piece. So that's a big part of the counseling section you'll see in the IMCI chart booklet. I'm gonna run over here off screen for just a second because I think it's important to show you what this looks like. And I forgot to bring this up earlier. So, my apologies. So, this is the IMCI chart booklet. All right, it's a standard protocol program. You can decide what page based on the chief complaints, and you can flip directly to that page. Now, this is an old version, so I use this as a demonstration model. This is actually previous protocols. Once you've identified where you classify the child, it'll give you treatment protocols, whether they can be treated here in the clinic or whether they immediately need to be treated and then referred to the hospital or to a higher level of care. So this is a really neat system. It also, in the back of the chart booklet, you'll find this chart booklet on our website as well, is the paperwork for implementing it. So if you have the paperwork, then on the other side of the paperwork is your narrative as a clinician. You can do a lot with just this little tool. Back on track. Sorry for the rabbit trail, but I wanted to show you what that looked like. Some of the big things that promoting breastfeeding does is really that it has been shown that it could decrease mortality by 24 to 27%, especially in the diarrhea cases, and it can avert 3% of the pneumonia deaths. So this is a big deal when we look at getting moms educated. So when you get to here and you've got a diagnosis, it's going to actually tell you where to go for the educational piece as well. The question is about HIV, and we see this all the time. Is it still appropriate to have an HIV-infected mom in these contexts of breastfeed? And the answer is the most appropriate infant feeding option for HIV-infected mother depends on her individual circumstances, including her health status and her local health situation, but should take into consideration the health services available in the area, the counseling and support. Okay, what does that really translate to? That's the way the standard reads, but what it really translates to is this, is that when antiretroviral drugs are not immediately available, breastfeeding may still provide infants born to HIV-infected moms with the greatest chance of HIV-free survival. So many of the contexts that we work in don't give us, there really isn't a lot of other options. And the studies that have been done in this context really say if you were here, that would be different. But if you're in a rural village, this is still probably the answer. May not be the answer that many of us practicing in this context would like to hear, but it still is often the best option for these moms and these babies. Okay, so there are 5 really basic recommendations for prevention and treatment interventions according to World Health Organization and these guidelines. Immunizations, obviously, no-brainer. Anti-home prophylaxis, we're going to give them warm medicine, right? Vitamin A supplementation, probably not something you're familiar with here if you're doing pediatrics in our country. Zinc supplementation, probably not something you're readily familiar with if you're practicing in this context, and then iron supplementation. Well, let me explain a little bit about why each of these, and maybe some of the rationales for them. So immunizations, I think we're all familiar with this one. If we're a clinician here in the States, we get that this is a pretty important piece. 20% of the 6 million child deaths that happen annually are really related to that, vaccine preventable illnesses. So that's something that we need to keep in mind as we work on immunizing these kids. And that's kind of goes back to the idea of what can we do when we're providing health care in the context of a church or a school. If we're doing real health care, it becomes really hard to kind of look at what are the immunization records of. Many times moms will have an immunization card, believe it or not. So we need to kind of look at what what they have available. If you're in a health center, this becomes much easier to fulfill because you're going to see that these charts are available and some of the records are there for you, and it's not such a you're not just guessing to see who's immunized and who's not. Children in developing communities, on average, receive about 50 to 70% of the daily required caloric intake. Now, when you add on top of that worms in their belly, it's not a context for good nutrition, is it? So that's why WHO has some pretty basic guidelines on treating pretty much all the kids in these villages with worm medicine. It may not be the best option. It may not be, obviously there are some other public health interventions that really need to occur there as far as making sure that there's latrines and that things are progressing at that level. But the recommendation really is to treat these kids for worms every 6 months. Vitamin A supplementation, this one may be, has anybody heard of this before? Okay. So most of you guys are not, you've been around the block, so you get why we're doing this. But this is kind of a basic standard. The question is we don't even have these doses of vitamin A available here in most of the time. So it's really hard to even get this level of vitamin A. But you can get it. There is an emulsified version that we used to buy that was per drop. But there's also, which is actually easier to give to kids because you can give it just sublingual. But you can get them in country usually. And the public health centers often will have vitamin A available. So you just kind of need to look in the context in the place you're working to see what is available. But we give the first dose any time after 6 months of age to all children. And then thereafter, we give them vitamin A every 6 months up to age 5. We give them an extra dose of vitamin A the same time and basically the same primary dose of vitamin A. What I'm not mentioning is the dose here because I think that if you haven't done this before, it's probably a little outside of the norm for you. We give these kids 100,000 international units at 6 months of age to 12 months and 200,000 international units at 12 months and above, and we do that every 6 months. So this has been shown to really, I've seen some varying studies. Some say it doesn't significantly reduce mortality, but there's a lot of studies that were done earlier that say that it does. And just in the context of strengthened immune systems, I think you do a lot with vitamin A supplementation. So there's a lot to this that we really need to look at and take very seriously. So this is still the World Health Organization guideline and recommendation. And I would see if you're treating kids under 5 in the developing world that you really do your best to sustain this. Zinc supplementation. When we talk about home management of diarrhea, we're talking, one of the things that we need to do is this idea of iron and zinc supplementation. Iron supplementation has been shown to impact child development over age 2, and zinc supplementation was shown to reduce diarrhea incidence by 18% and pneumonia incidence by 41%. So that's got a lot of potential in there, which is why you'll see zinc supplementation is a primary standard within the guidelines for IMCI. And they will tell you exactly, this is the child that you're seeing, this is how much zinc you're going to give, this is how much vitamin A you're going to give. And that's what this kind of slide refers to. You're going to kind of look at this, but it'll talk about counseling mom, talk about rehydration formulas, and it'll talk about zinc supplementation, and they'll even give you the doses. So they make this really, for a clinician, it's really simple. If you just look at the guidelines, it'll tell you the ideas. But, we give zinc supplementation from 2 months to 5 years for persistent diarrhea for sure. This is the one area that it's really been shown to help, is with these kids with persistent diarrhea. And it takes some time to teach mom how to do this, because I haven't seen zinc in anything other than pills, which means it's got to be crushed, and it's got to be, which getting a young child to take anything that's crushed is always a work of a miracle itself. So those of you who have struggled through that, you kind of know, but the education piece on this is huge. So the standards are easy to take away. It's just kind of look and see what it's really going to take to do this. Also, the vitamin A and mebendazole guidelines are kind of outlined in here. It's real easy they've kind of created this in a real easy way to follow. The other thing is iron. We see a lot of these kids that come in and they need transfused. Their hemoglobin is just in the tank, and it's so low. And sometimes at the community level, you're really not going to be able to check your hemoglobin, but you can if you have. There's a group in the UK, and I'm trying to remember the new name for it. It might be the, it was TALC, Teaching Aids at Low Cost, but they recently changed their name, and you can probably still find them under TALC. So Teaching Aids at Low Cost has these little finger stick for hemoglobin, so you can get a pretty good actual lab test with just a little stick. But most of the time we don't have that ability. So they recommend, not necessarily in children at this age, looking at the palms as palmar pallor is something that we investigate a lot in this age group at the community level. If you have other options to do the labs, obviously, but this is something that gives us a little better indication than probably some of the other things that we've seen by looking at conjunctiva and their mucosa. Palmar pallor is a big one. When we suspect these kids are really anemic, and many of them are, a lot of these kids get transfused that have severe acute malnutrition. we are going to treat them for malaria, oftentimes prophylactically, if they're in a high malaria prevalence area. The caveat on that is that each country, each Ministry of Health has its own tweak and its own modifications to the Integrated Management of Childhood Illness guidelines. So follow the country guidelines that you're in, because this is the one area that may vary, because nobody wants to build malaria resistance medications. So this is something that we want to think about. But all these kids in many of the countries that we work in are going to get malaria prophylaxis, or they're going to get malaria medication. They're going to get mebendazole, and they're going to get a lot of counseling with mom. And we're going to give them, at some point, we're also going to give them iron. Assessing malnutrition. Who's seen these little armband things? Anybody used them? Now, this is probably this mid-upper arm circumference bands. It's probably the most effective assessment for looking at kids from at least 6 months to 5 years, because we can really get a good snapshot. And all of the studies really indicate that this is just as effective as weighing and measuring and graphing them as far as kind of assessing their nutritional status. So this is a biggie. And you can get these from, we've ordered some from UNICEF. We're actually looking to actually make these in a way that they're indestructible. I've had some talc, that same organization, the Teaching Aids at Low Cost, would make these branded, and we used to order them, batches of them. But they're a good thing to have. I think, like I said, we're trying to get some made up. I think MSF actually has one that is on a sheet of paper that you can print out and then cut out, but it's not as durable unless you put it on, even if you put it on cardstock, they tend to disappear on you. So if you can get them from talc or UNICEF, they're really a great tool for you to use in assessing kids in the developing world as far as the nutritional status. So who's familiar with the Z-scores for kids with malnutrition? Anybody? Okay. Basically what we're saying is how many standard deviations from the mean is this kid. Here, they're on the upper ends most of the time. They're on the lower end. So are they 1 or 2 standard deviations from the mean? Is what we're trying to assess when we graph these kids, and we kind of assess where they're at. Based on what? What's the norm? What do I mean by that? What am I assessing them against? If we want to graph these kids based on normal height for weight for age, right? And that's usually how we get these numbers. Ultimately, you can do the same thing with the mid-upper arm circumference band. In fact, what we have learned is that the mid-upper arm circumference bands and weight for height are roughly equivalent as diagnostic and prognostic parameters. So if you don't necessarily have to weigh, measure, and graph all these kids to get the data that you're looking for. The mid-upper arm circumference data will do it for you if you use them. This is also out of our Lindsay's program in the Congo. That's the weight for height for age. So who knows the difference between marasmus, malnutrition, and kwashiorkors? Okay, so we have a handful of people who know the difference. This is the classic marasmus. But you can see a clinical mixture of these patients as well. You can see marasmic kwashiorkors. You can see both in some patients. So I would say, this is also, unfortunately, one of Lindsay's patients. most of the time see marasmus in younger children who have not been breastfed. This might be a little bit older child. Oftentimes you'll see CP kids and kids with chronic illness that appear like this. They're a little older in some of the contexts that I'm sure you guys work in and that we work in. That goes back to the classic kwashiorkors. So that being classic marasmus, this being more classic kwashiorkors. Kwashiorkors can fool some folks if you're not paying attention. And sometimes you have to actually say not only feet, but look at their forehead, and we'll press our finger into their forehead to determine whether they have pitting edema in their forehead as well. That's a really big sign. But the classic kwash is edema, dermatitis, hypoalbuminemia. Does anybody know where the term kwashiorkors came from? They say it was a Ga term from West Africa, that it was it originally meant the child, or the disease the first baby gets when the second baby comes. Meaning that baby 1 was weaned, and now baby 2 is getting breastfed, and baby 1 doesn't have the protein level. So you begin to see protein energy malnutrition with fluid leakage peripherally. Nurimamba. So there's some things called ready to use therapeutic foods. Plumpy nut is probably the most commercially available one. And you'll see that most of the community-based nutrition programs for child health actually will use plumpy nut. Peanut-based proteins are highly absorbable, and they seem to turn these kids around pretty quick. Everybody asks, well, what about peanut allergies? We just don't see that in the developing world for the most part. I pray we won't, because peanut-based proteins are really one of the best ways to go. But it's expensive. That's the downside to it. So there's a couple of different things that you can do. This is Nurimamba. This is a recipe basically to make plumpy nut. And that's, if you look towards the latter part of my book, you'll find this recipe in there, but you can create your own plump. This was actually created by Partners in Health in Haiti when they started growing peanuts and making this to combat community, as a community-based malnutrition strategy. The other one that I would suggest you really think about, if you're doing this and you're working in the same community long-term and you're trying to make a transition or transformation, if it's tropical, look at moringa. Moringa oleifera is probably one of the most effective community-based nutrition strategies for combating childhood malnutrition in villages that you'll ever find. And it's a scruffy-looking little tree that grows like a weed in the tropics. It doesn't need a lot of water. It will thrive. If you trim it back, it can grow like a bush. And the leaves contain pretty much every amino acid needed for the human body, and then some. And they're also very high in beta carotene and vitamin A. So you have this kind of nutrition tree that, if you dry the leaves, they are odorless and tasteless, and you can grind it up and put it on pretty much anything. So it works really well, and it's something the community can do rather than being dependent on an outside resource. So remember moringa, look it up. You can YouTube it. There's lots of videos about moringa. But in Nurimamba or plumpy nut, also good community-based strategies. Let's look at inpatient really quick. I want to show you a video at the end here, so I'm going to speed through some of these. One of the things that I want you to, I didn't get it on here. What's the name of it? Elena is a new WHO app that you can download that will give you all the standards right on your phone. So it's very helpful if you haven't worked with kids at the inpatient level, and whether if you're trying to manage these kids, it's really probably an important tool. So there is a 10-step stabilization process and stabilization and recovery process for these kids on the inpatient level that suffer from severe acute malnutrition. And this is one of the kids that came through Lindsay's program that goes from, you can see, really bad here to plump, healthy looking baby. In this stabilization process, the first couple of days is really about managing hypoglycemia, managing hypothermia, and managing dehydration. How much time do I have? I'm sorry. 15. Oh, okay, we're good then. The first couple of days are really about kind of managing those particular things. We don't jump into electrolytes right away for a number of reasons, but then if you can get electrolytes and you're looking at these kids, obviously that's something we want to get addressed within, initially, but really very seriously as we move past that initial stage of dealing with the hypoglycemia and the hypothermia and the dehydration. Infections we're going to start treating right away. Micronutrient supplementation, that is going to, one of those things that's going to go through all through the whole cycle of both stabilization and rehabilitation. We're going to implement cautious feeding initially, and then that's going to increase in the formula as we move through this process with some of these kids. These kids are usually going to be tube fed. If they're as sick as that, this is what we're looking at, a kid that's really unable to stand, walk, or eat, or at least eat. They do get to a place where they don't care about eating anymore. It's just, they stop eating, period. And the only way to address this is to tube feeding. So as we go through this process, there's a whole set of protocols, but I just wanted to kind of give you a quick eyeball of it. When we deal with the first 1 through 5, or that stabilization phase, which is that first week, we're dealing with hypothermia, hypoglycemia, dehydration, electrolyte abnormalities, and infection. That's the first things that you're going to manage. And then that's Daniel Cummings, who's with us in Angola, by the way. He's an ER doc, but he's one of 2 docs. He and his wife are there alone with a 200-bed hospital. So if you ever want to go to Angola, I know somebody who needs some help. The recovery phase gets us into replacement of micronutrients, and this is a big piece. And then as we actively start refeeding, we're going to go with an F75 formula and then work it up to an F100. And then as soon as we can, incorporate local fluids as soon as we can get this kid eating again. But it sounds simple, right? Oh, not so much. But these pictures are also from Lindsay's program in the Congo, because they make a protein-rich porridge. As soon as the kids actually can start eating, we start feeding them. And moms do that. And then moms actually mix the porridge there. So they teach mom how to make the porridge, and they're all working together to do this for their kids. So it's really kind of a cool program. That's just some pictures of F75 and F100. There's something I want to share with you guys. Who's heard of the FEAST study? Okay. So when we manage fluid resuscitation in children overseas, it looks different in developing communities. And most of that adjustment has come from this study. Now, the WHO standards have not fully shifted yet, but I think the research is there to certainly warrant a significant shift. Most of the time when we're gonna manage these kids and fluid resuscitate them, if they're just dehydrated. Now, this isn't, if they're septic, let me rephrase that. If they're dehydrated from diarrhea, from normal issues of dehydration, we will fluid resuscitate them with IV. We try to do as much as we can via NG tube with fluid resuscitation on these kids. And this study is really why. So I wanted to show it to you. And the study, you can download it on our resource page at healthservicecorps.org, and just go to clinical resources and you'll find all this stuff that I'm talking about there. But I wanted to just show you this study. It'll take us up to about the time we're going to close. So this is a really fast overview. And I will tell you that if you want to dive deeper into this stuff, come visit us. We're about 4 hours north of here, and we've got some classes that do exactly that. InMed also has some great classes, and Nicholas Caminales is downstairs. They have a booth here, and they do this kind of clinical education as well. We kind of approach it from the missional perspective. They have more of a global health approach. But so let me show you this, and then I'll be around to answer questions after the fact, okay? At least I hope I'm going to show it to you. Okay, let's try it the old-fashioned way then. We're going to get here. Oh boy, what do we do there? Hey, that looks hopeful. Oh gosh, guys, I'm sorry. I'm going to leave it alone this time. Okay, everybody pray. Hey. Oh. That's what I get for being impatient, right? Okay. I think we're good, though. There we go.
5-year-old Chen Loi has just arrived in hospital with suspected malaria or sepsis, a bacterial blood infection. Every year, these illnesses kill more than 2 million children worldwide. There are effective medicines, which Chen is being given, but she's already in shock. She has a weak, rapid pulse with cold legs and arms. Her body is concentrating all the blood to the vital organs in an effort to stave off death. To save her, the doctors need to keep her alive long enough for the medicines to take effect. In wealthy countries, children in shock like Chen would be given a large emergency dose or bolus of fluids in an effort to restore circulation. But there, doctors also have ventilators and other life support machines to keep children alive. Like most African hospitals, ours does not have such equipment. So, as a doctor working in Africa, I need to know if it is safe for me to also give boluses. Or should I give fluids more slowly just to replace what a child should normally drink? Even in wealthy countries, the evidence to answer this vital question is weak. The FEAST trial is the first large randomized trial anywhere in the world to see if it is safe and effective to give boluses of fluids to critically sick children with shock. My hospital in eastern Uganda was one of 6 sites in Uganda, Kenya, and Tanzania where the trial was carried out. The FEAST question is very important here because too many children still die of malaria and sepsis. They arrive in the hospital already in shock and die in the first hours. So finding out how to use fluids to keep them alive a little longer could save many lives. We started with intensive training on basic emergency care to allow staff to quickly identify and give priority to very sick children.
1, 2, 3, 4.
These are important skills which require people to work as a team. These simple measures alone improved survival of all children at the hospitals where FEAST was done. Over 2 years, we recruited more than 3,000 children with shock caused by malaria, sepsis, and other illnesses that produce fevers. We did not include children with diarrhea, trauma, or burns who need extra fluids. The children were divided randomly into 3 equally sized groups. 2 groups were immediately given an emergency fluid bolus. One group saline, the other albumin. The third group were given fluids more slowly at the amounts needed to maintain normal levels.
The main outcome that we're interested in, and which we called our endpoint, was to ascertain the number of children who survived within the first 48 hours of admission.
The answer came sooner than expected. The trial was stopped slightly early by the committee overseeing safety.
The results showed that 89.4% of children who received boluses survived the first 48 hours in hospital. However, children who didn't receive boluses but were given fluid more slowly did better. 92.7% of them survived. This difference is significant. It means if we give boluses to all African children with shock, as in the FEAST trial, between 3 and 4 in 100 would be expected to die as a result of the treatment.
Had a bolus. So boluses were not saving lives.
When the trial team was told the results, there was general surprise. The trial found clear evidence that giving boluses was actually harmful.
The results surprised me because I saw a couple of children improving after getting big amounts of fluids. But I was more surprised because the results were against the current recommendations by WHO and against what is the normal practice in the wealthy countries, and this surprised me absolutely.
We are quite sure that the results are accurate. Every piece of data was checked several times.
The study was conducted to a very high standard. It has achieved a level of adherence to the protocol and a level of retention I haven't seen in my 25 years of working in clinical trials. And for all these reasons, I believe that the results coming from FEAST are reliable.
So I'm going to cut us off there because we're running short time, but I wanted to share that little video with you. There's a couple more minutes if you want to find this on YouTube. Just type in FEAST study. There's some good But there's an overview of the feast study and some of the literature that came out of that on our resource page on our website. Because I think how we manage these kids, this study, specific study, is really transitioning and transforming how we use fluid management in kids with sepsis. I wish I could say we had some time for questions, but we don't, but we are going to at the end. So there are some note cards. I would encourage you to write your, if you have questions, write them down. And there's some note cards out on the table. You can get those and write them down and have them later for our panel of all the speakers at the end of the day. So thank you so much for your time, and I hope this was helpful.